Hi, I'm Dr. Val Brule, your narrator and main content creator for these Bedside PEWS early warning system modules, which I will be calling Bedside PEWS throughout. I'm a pediatric intensivist here at the HSC Children's Hospital of Winnipeg, and I'm also the medical lead for inpatient quality improvement. I'm the lead for the Bedside PEWS project. The content of this module was also created by child health nurse educator Alexandra Austria, with some content from Bedside Clinical Systems, the company that owns Bedside PEWS. Welcome to Module 3, Practice Scenarios. This module will walk you through numerous scenarios using Bedside PEWS. This is meant for you to understand how Bedside PEWS is used in practice, and you can revisit these whenever you would like. You can also ask questions to super users, nurse educators, the clinical nurse specialist Holly Beckering, or myself. Patient number 1, Sven. Sven is a 3-year-old, ex-24-week premature male. He has a tracheostomy and ventilator and is dependent on this due to severe bronchopulmonary dysplasia. He has a G-tube for feeds and is otherwise healthy. You notice he is developing a rash to his G-tube site that is red, hot to touch, and has some pus-like discharge. You go to take his vital signs. His temperature is 39.5 degrees Celsius, heart rate 185, rest rate 50, and blood pressure 95 over 56. His sats are 90% on 35% oxygen, and he's on settings of pressure support or PSV with a delta P of 10, PEEP of plus 6 centimeters of water. Note these values are not important if you're not as involved in these settings, but just rather to know what the settings are. His capillary refill time is 2 seconds, and he has mild subcostal indrawing. So for our patient, we select the 1 to less than 5 years old because he's a 3-year-old male. And you can see that all the vital signs are plotted here. You can take your time to calculate the score. Please feel free to pause the video if you would like to take more time to do this. The bedside PEWS score is 12. With the number 12, you take the greater than 8 score match care recommendations, which means that a senior nurse review should be within 15 minutes, and you can consider notifying respiratory therapy. You should notify primary medical review, as well as secondary medical review. You should consider continuous monitoring, saturation, and cardiorespiratory monitoring. Consider a rapid response team or code blue, and consider transfer of patient to a higher level of care as per site policy. And while the child is showing signs of being more unwell, there should be no other similar patients cared for by the nurse. In this case, the patient would likely already have a higher score because they have a tracheostomy and ventilator. So therefore, this is why most of this is recommendations. Um, and I'll go into details about what you do if your patient has a high baseline score at all times. In this case, you treated the patient with acetaminophen and suctioned through the tracheostomy tube. After doing this, you repeated your vital signs after a period of time. And now the temperature is 37 degrees Celsius. The heart rate is 120. Blood pressure is 94 over 55. Rest rate is 30. Saturations are 95%. You have no change to the ventilator settings, and your oxygen is 30%. His capillary refill time is 2 seconds, and he has no work of breathing. When you plot this, you can see very dramatically on the graph how the heart rate drops, the respiratory rate drops, and you get an improvement in your saturations. You can pause the video if you would like to make a score again. In this case, the bedside PEWS score is now 5. You chart on the G-tube site for the nursing assessment, where we have found that it is abnormal because it was documented to be having redness and pus-like drainage. So it would be documented in likely spot number 1 of the G-tube. stating that it's abnormal, or WA to see wound assessment sheet, in which case notes would be written about the specific details. So just a note, because the patient has a tracheostomy and ventilator, they will always have a subscore of 4 for the respiratory support. This means there are some patients like this who will have a higher underlying or baseline clinical condition score. This would also fit for patients who may have complex congenital heart disease or other technology-based settings. If the patient does establish a high baseline bedside PEWS score, the team, including the medical the physicians, in discussion with the nurses, will order specific parameters for escalating. For example, if the score is always 8 as a baseline, the team can consider routine vitals of Q4 hours, but would need to have parameters to escalate to more frequent vital signs. These children genuinely are more fragile, and smaller changes can make a huge difference in clinical condition. Therefore, you wouldn't change what you're writing and make the score lower. You would keep the score to be high, but recognize that these patients are at higher risk at all times. However, with that understanding, you don't have to always do vitals every 15 minutes because for them it is normal. This should be well established and a discussion with the medical most responsible physician to ensure everyone's on the same page about the escalation. Scenario 2, Mirabelle. Mirabelle is a 15-year-old female admitted with respiratory distress that has not been diagnosed. The initial vital signs are a temperature of 36.7 degrees Celsius, heart rate 85, respiratory rate 15, on zero point 0.5 liters per minute of oxygen, which is low flow nasal cannula. Her saturations are 96%, and blood pressure is 115 over 75. Capillary refill time is 2 seconds, and work of breathing shows mild nasal flare. For this, you would chart all the vital signs in these categories. For respiratory effort, it would be considered mild. The score calculation is a score of 3. This would mean every 2 to 4 hours, you would be documenting vital signs. A senior nurse review would be within 8 hours, primary medical review the same, and secondary medical review would be routine. So that means, however, you normally are communicating about your patient to the most responsible physician, which is often at rounds or during any scheduled or planned reviews of patient lists. Mirabelle now goes to the bathroom and is back in bed, and you've repeated her vital signs. Now you can see that her temperature is 36.7, heart rate 110, respiratory rate 32, FiO2 zero point 0.5 liters per minute, saturations are 80%, and blood pressure 123 over 80 with a capillary refill time of 4 seconds. You see that she's now having nasal flare, tracheal tug, pursed lip breathing, sternocleidomastoid use, subcostal indrawing, and she's sitting in a tripod position. You can see very nicely on the graphics how the vital sign changes. And even if you don't calculate it, I'm sure you're all imagining and can see that the score has gone up quite a lot. In fact, her score is now 18. In this case, you've had a significant change to your patient, so you would want to have a review quite quickly. You would consider your reviews within about 15 minutes and consider, does she need to have continuous monitoring? Do you need to call code blue? Is there any other things that might need help? In her case, with such a drop in saturations, you may be considering that she might need a code blue or a rapid escalation with an RRT. It depends on the clinical opinion of the people assessing the patient at that time. Scenario 3, Olaf. You have a 10-year-old male named Olaf who was in an ATV injury who's been admitted to CK3 and doing rather well. His initial vital signs are a temperature of 36.7 degrees Celsius, heart rate 93, blood pressure 107 over 68, respiratory rate of 17, on room air or FiO2 of 0.21, saturation 97%, capillary refill time 2 seconds, and he has no work of breathing. In this case, your bedside PEWS score is 0. As you can see, his vital signs all fit in the white part of the documentation. So at a glance, you can see that the score would be 0. In this case, you would just do all routine vital signs, which for an admitted patient is generally Q4 hours unless otherwise ordered. When you go back to reassess Olaf, you notice that his abdomen's actually getting bigger. You chart his abdominal girth, and then you notice actually he's less responsive when you had thought he had been sleeping. And you go to chart his GCS, while another nurse you've asked to come help you repeat his vital signs. At this point, you see his temperature is 37 degrees Celsius, heart rate 153, blood pressure 65 over 41, respiratory rate 26, FiO2 0.21, saturation 89%, capillary refill time 7 seconds, worker breathing, minimal effort being made by the patient at all, and having some subcostal indrawing. Of note, this is how the neurologic assessment can be documented with a GCS. It also will go through the specific details of each of the score. Your GI assessment, you would be able to document your abdominal girth and your bowel sounds and your abdomen there. If you're feeling anxious while you're doing this, you're not alone. You can always pause and you don't need to calculate the assessment without calling for help. And you can do that at any time, and nobody should ever be asking you for a score before you call for help for things such as a code blue. However, for the purposes of this exercise, you will document all the scoring numbers and you can calculate. So in this case, with his vital signs, you calculate a score of 22. Of note, numerous numbers are in a critical value, so that reddish purplish color, which would always indicate you may want to consider calling for help right away. Again, it's in the greater than 8 section, and you may want to assess the need for CPR, rapid response team, code blue, or escalation of care. In this case, the patient clearly or potentially now you see that the patient has impending arrest, and you rightly call the code blue. After calling a code blue, the patient is urgently intubated, a CT scan is done, and he's given urgent blood. He goes to the operating room to repair an arterial bleed and a duodenal rupture. Great job. Finally, our last scenario is Elsa. Elsa is an almost 3-month-old female, status post Norwood Sano for classical, which is mitral atresia, aortic atresia, hypoplastic left heart syndrome. The initial vitals for this patient are temperature 36.4 degrees Celsius, heart rate 170, rest rate 85, blood pressure 76 over 45, saturation 95%, FiO2 1 liter per minute, capillary refill time 4 seconds, and worker breathing shows subcostal indrawing and grunting. Of note, like all scenarios, we've switched forms to match the age. So in this case, we have a less than 3-month form. Initial vital signs are documented here, and you can calculate the score. In this case, the score is 13. In this case, again, you have greater than 8, so I won't go through these all again, but you consider that the patient needs rapid help and review by your medical team and senior nurse. And if you're concerned, you can call for a code blue, rapid response team, or any other help. In this case, you turn off the oxygen and give the scheduled IV dose of furosemide, which is also known as Lasix, and Elsa now starts to look a lot better. Her repeat vital signs show a temperature of 37 degrees Celsius, heart rate of 146, respiratory rate of 53, blood pressure 77 over 50, saturations 82%, FiO2 0.21, which is room air, capillary refill time 2 seconds, and she now has no worker breathing. Her score is now 2, which would be in the normal range. So what happened for Elsa? As a point of review, a Norwood Sano patient have normal saturations of 75 to 85% because they have a mixing and shunting lesion. In this scenario, they had pulmonary overcirculation with increased congestive heart failure symptoms. So, this wanted to really highlight that some children, what might be considered abnormal vital signs, are actually normal vital signs for them. And children with congenital heart disease may always be at a higher baseline level, although in this case for Elsa, she's in a fairly normal level, but her saturations will always be a higher score because they're not normal, but they are typical and appropriate for her. That's the end of the main practice scenarios. However, we'll always be happy to make new ones for you and to review any cases that you might have. Overall, bedside PEWS works when you use your clinical judgment with the score matched care recommendations and follow up closely. Bedside PEWS does not tell you what is wrong with the patient, only that they may warrant closer follow up. It does not replace the team expertise. And you would never be expected to calculate a score before you call for help if it is clear the patient needs it. For example, in some of these scenarios, you likely would have called a code blue well before you got all the vital sign measurements, which is appropriate. Finally, we'll just review the S-bar communications. So, some important communication things to consider when you're talking about your patients is what is your trending score? What indicators made up your score? What is the recommendation? And what is the plan? SBAR is a really nice organization system for how you're going to describe your situation. This is a different patient than any of the scenarios, but a good way to think through the SBAR or how you would communicate. So SBAR stands for situation, where you describe the situation with a clear overview of the issue. Background, which includes a brief history, what got you to this point, and what is the trend. A is assessment, so summarize the facts and your assessment and give your opinion as to what's going on. And finally, recommendation. What actions are you asking for? What would you want to happen next? What do you think is going on really for the patient? And what would you recommend as the next things? So, for example, you have Joey, who's 8 years old with pneumonia. He has increased work of breathing and oxygen requirements in the last 2 hours. That's the situation. The background is that he was admitted overnight with IV antibiotics started and was on 2 liters per minute of oxygen. Now he has moderate work of breathing and O2 requirements have increased. Your assessment showed that bedside PEWS was initially 3 and now increased to 8. His vitals are heart rate 170, respiratory rate 45, oxygen from 2 liters per minute, now 8 liters per minute at face mask. He has moderate work of breathing with desaturations to 88%, intermittently coughing, and lethargic. What you're requesting is for service, so the primary medical review to come, for a respiratory therapist to come, to consider continuous monitoring, and to consider a rapid response team. Of note, you can always call a rapid response team without discussing with service, as always, and in which case you can still use SBAR to describe the whole situation, in which case your recommendation would say, I would like you to come see the patient. The recommendation portion, really to highlight, is using your bedside PEWS recommendations that go along with the score. It helps you objectively decide when to do these things, but doesn't tell you exactly what to do. And the consults and the monitoring are recommendations for consideration. However, it should be the documentation should be within the 15 minutes and it should be escalated all the way to the most responsible physician as soon as possible within those 15 minutes. In summary, bedside PEWS augments clinical judgment and alerts you to clinical concern for deterioration. Clear communication will increase team assessments and care for patients. Bedside PEWS helps trend response to therapy. And of note, you really do not need to wait to calculate a score before you call for help if you need it. Thanks very much for participating in this module, and as always, please reach out to myself, any of the clinical educators, the super users, or Holly Beckering, our clinical nurse specialist, with any questions.